Hi everyone. I'll be talking to you guys today about some of my PhD work, and it relates to what I'll be working on here a lot in terms of the methods, at least, if not the actual pathogen system. This picture here represents Ho Chi Minh City. This is a square downtown, and one of the big problems in Vietnam that is kind of understudied in the grand scheme of things is the HIV and hepatitis C epidemic among injection drug users. So it's a problem that doesn't affect a large swath of the population, but it's very concentrated in this particular population. So a little bit of background. There's very high co-prevalence of these two pathogens among people who inject drugs because they have a shared transmission route. So both of them are bloodborne, and they're transmitted through shared needles often, and also unsafe medical procedures. These two pathogens, HIV and hepatitis C, have potentiating effects. So as many of you might be familiar, HIV affects the immune system, and it makes it more difficult to combat other infections. When patients are co-infected with hepatitis C, it can speed progress of hepatitis C infection and make it more severe. In this study, we're going to focus on a highly co-infected population in Ho Chi Minh City, Vietnam. As I mentioned, there's a high burden in general among drug users, and it's exacerbated by poor linkage of these individuals into health systems. I'm going to be using a couple terms here, so I'm just going to take a minute to define them now. ART stands for antiretroviral therapy, and that's the treatment for HIV. MMT stands for methadone maintenance, and that's a treatment program for injection drug users. Hepatitis C treatment exists, but it's currently unaffordable. It's very expensive even in the developed world. But there has been a lot of news about it recently because traditional methods of indirect therapies are being replaced by these new direct-acting drugs, which are highly effective. They have much shorter treatment durations, but they're still very, very expensive. The drugs, however, are not actually that expensive to manufacture, and they're already being provided at low cost in some populations. So, for example, in Egypt, a 12-week course, which usually costs about $84,000, is now being provided for $1,000. So one of the goals of this study is to look at this population and see whether it might also be a good target population to providing lower-cost therapies. So the questions that I'm asking in this study are, how can we model the relative impacts of antiretroviral therapy and methadone maintenance scale-up, and then also potential future rollout of hepatitis C treatment in this highly co-infected population in Vietnam? What can we do now to prepare for this potential rollout in the future if hep C treatment becomes more affordable? Then the other question here is, will hep C treatment have any additional benefit on top of the already planned rollouts of antiretroviral therapy and methadone maintenance? So a bit about the HIV epidemic in Vietnam. As I alluded to, it's a concentrated epidemic, so it's different than the epidemics that you hear about in places like sub-Saharan Africa, where the prevalence in the whole population is about 50%, in South Africa, for example, in certain areas, and everybody is at risk. Here, the risk is concentrated among specific populations like commercial sex workers, men who have sex with men, and injection drug users. A little bit of why injection drug users are at such high risk. This shows a graph of proportion of drug users who have shared equipment. This is from about 10 years ago, but the numbers are still relatively similar. And that's Ho Chi Minh City. A bit about hepatitis C. I'm not going to go into sort of full pathogen details because of the short time here, but it's a virus that infects blood and liver. It replicates in the liver, and it usually has a pretty long treatment duration with not terribly severe symptoms for the first 10, 15 years, but there's high risk of developing liver cancer and cirrhosis. And one of the big issues is that, particularly in Vietnam, there's very high co-infection prevalence. So nearly 100% of HIV-positive drug users are co-infected with hepatitis C. So we're taking a modeling approach to this and looking at a mathematical model of these two epidemics and then using that model to make predictions about different interventions. So the design that we're using is we look at the demographics of people who inject drugs, HIV progression, hepatitis C progression, and then we calibrate these models to prevalence data to get parameter estimates. And then we using this model, we project forward 10 years to look at varying levels of prevalence after intervention, sorry, of incidence after intervention. This is the basic model structure. I'm not going to go through it in a lot of detail, but we have basically the hepatitis C progression layered on top of HIV, layered on top of injection drug users. We assume that HIV decreases the probability of spontaneously clearing hepatitis C. So hepatitis C is something that people can recover from spontaneously without treatment, but the chance of that is pretty low if they're HIV co-infected. HIV also increases the probability of developing one of these severe sequelae, like cirrhosis or liver cancer, that we lump into chronic liver disease here. We assume that if somebody is treated for HIV, they reduce this increased risk. We assume that ART was not available until 2005, excuse me. And then we also assume that being on methadone maintenance is associated with increased adherence to antiretroviral therapy. We assume also that hepatitis C treatment works equally well for mono and co-infected, and that's because we're assuming these new drugs that are being implemented now. The previous classical treatment did not work as well for co-infected individuals. This is a bit about previous interventions. So ART is available in Vietnam, but as you can see from the graph on the, I'm sorry, I don't know my right from my left, the one on this side, the proportion of patients who are eligible for antiretroviral therapy, meaning that their HIV has progressed enough that they're eligible to be on therapy, is still nowhere near where it should be. Methadone maintenance is also being rolled out slowly. There have been a few pilot programs, and there are clinics that exist in a few cities, but again, the coverage level is pretty low. The good news is that these pilot studies have shown pretty good impact and retention, so most people are still enrolled in methadone maintenance after a year, and up to almost 80% of them actually stop injecting drugs. So these are our model fits. The data that we have is from respondent-driven sampling for HIV and then from a few different seroprevalence studies for Hep C. So we use this is fitted prevalence, but then we validated it by comparing the incidence data from the model to other incidence data and found that it fit pretty well. I don't know why these are coming out. They're quite dark, but you can probably still see the picture. When we scale up access to antiretroviral therapy, we see big differences, big changes in HIV incidence, prevalence, and deaths, but there's very little change in Hep C, which makes sense because ART is only treatment for HIV. When we scale up methadone maintenance, however, we see differences in both pathogens in terms of incidence, prevalence, and deaths. And looking at these together, it's a bit hard to tell from this photo, but when we scale up ART and methadone maintenance, the difference in deaths that we get is only among HIV-positive individuals. So we don't really see any difference in deaths due to hepatitis C over time. Those are the yellow boxes, and it's sort of hard to see, but the red boxes are getting smaller and the yellow boxes are staying the same. So for looking at scaling up ART and methadone maintenance, we see HIV is impacted by both of these scale-ups. Methadone maintenance is actually better for reducing incidence. ART is better for reducing HIV deaths. But for Hep C, methadone maintenance is the only one that has an impact, with no immediate impact on deaths because they're only averted, because the course of HCV infection is so long that you would only see them averted much after 10 years. So now we're looking at Hep C treatment rollout. We see that we implement it after looking at maximum scale-up of ART and methadone maintenance, and we're looking at the impact on deaths. And we can see that there are many deaths that are not averted with ART and methadone maintenance coverage. So now if we're looking at the yellow strips, once we start scaling up Hep C treatment, you can see that there are all these deaths that we can now avert by rolling out this treatment. So the marginal benefit is huge. There's one caveat, which is that right now Hep C prevalence in this community is so high that treating individuals will send them back into the susceptible pool, and you might actually see a spike in incidence initially when treatment is rolled out if the Hep C prevalence isn't reduced enough beforehand by methadone maintenance scale-up. But it's still worth doing because the overall prevalence will still go down. So conclusions here, scale-up of ART can lead to reduced HIV burden, but has no impact on hepatitis C. Methadone maintenance is good for both, but Hep C treatment has really good marginal efficacy in terms of deaths averted on top of previous scale-up of methadone maintenance and antiretroviral therapy. There's this reinfection caveat, but still worth doing. Methadone maintenance is being scaled up right now, but there's currently no plan for Hep C treatment rollout. And then the kind of punchline is that Vietnam is now transitioning into middle-income status, which means that a lot of foreign funding sources are starting to cut off. So it's really important to plan the most efficient rollouts for both of these therapies as soon as possible. Thanks. And to all my collaborators on this.